Everyone, welcome. Really glad to be here to talk about collaborative care. And just to let you know, I do watch the chat. So if you feel like you want to put questions in the chat, comments, feel free to put them out to the group. Or if you're feeling shy, then also feel free to just message me privately. And I'm glad, and I may answer it as I go along, or may stop and answer it, or we'll certainly have time for some Q&A at the end. I really want to be able to answer all of your questions about collaborative care. What's helpful is if you put in the chat, if you can, just sort of what your role is, so that I know, you're a potential care manager, you're a practice administrator, you're a medical director, so that I have a little bit of a sense of who's on the call. So we're going to talk about collaborative care in detail. There's some things you need to know before you start off that might be new information for you. Collaborative care is a primary care initiative. I love behavioral health leaders. I am one. I'm a psychologist and social worker by trade. However, this is really primary care, so that doing this without the involvement of your medical leadership, medical directors, is really, really different or difficult, because this is a population health approach. Sort of what we've done to this point is we say, okay, we've got this group of people and we think they might be eligible for counseling, right? Or we might want to give them some behavioral health treatment. However, one of the things that we know is that this is really your entire population. Like if I were in your organization and I ran a report of all the people on depression meds that hadn't touched behavioral health, those are all people that are collaborative care patients or individuals. And a lot of times people say, well,
no worries. I appreciate you checking in. We finished up.
Oh, okay. Thank you for catching that and muting. So one of the things people also often say to me, and I see some behavioral health providers in, is we already have, behavioral health. I see some FQHCs on the line, and that's great. And when you think about collaborative care, actually sits alongside your embedded behavioral health services and expands your ability to treat more of your population. So incredibly helpful to be able to do that. And it's super important to understand the model, to have a really deep understanding of the model, and particularly the treatment choices. So tonight, when you're at the dinner table, or maybe later on, we have some folks on the West Coast time, you're sitting around lunch and people say, what's that webinar you went to? What is this collaborative care? That really collaborative care is an evidence-based model to identify and treat patients with measurement-based behavioral health conditions and health settings. Notice I did not say depression and anxiety. Collaborative care has really transitioned. Pretty much if you can measure it, you can put it in collaborative care. It's why we now include ADHD for kids, trauma with the PCL, many different diagnoses, because if we can measure them, then we can put a system in place and we can really engage them and use collaborative care. I always like to give a bit of the history. So collaborative care used to be Impact. A lot of you heard, Project Impact maybe years ago. So Project Impact came out of a very large research trial, 1,800 patients, 400 primary care providers. At that point was seniors in depression. It has morphed since then. And one of the things actually is, for many of you following some of the collaborative care things, the AIM Center, sort of the initiator of collaborative care and where it really started, did a 20-year anniversary yesterday. So collaborative care has actually been around for a long time. It is evidence-based, meaning that collaborative care as an umbrella is evidence-based. There's well over 100 randomized controlled trials that show it's more effective than usual behavioral health treatment, that it saves time and saves money, that it's more efficient care, that it has an impact on chronic conditions. And so really important. It is economically sustainable, and we can answer questions about that. Unless you're in a state where the codes haven't passed yet for Medicaid and you have a lot of Medicaid patients, then potentially you might actually have some difficulty. but Medicare, Medicare Advantage, all of the commercial plans, and Medicaid in 34 states reimburse the code. So it is actually possible to be economically sustainable as well. And you don't even need to add it for your commercial contracts. It gets auto added in, so you don't actually need to do anything. So just to start off, a couple things I like to do right from the beginning is take on some of the myths. So collaborative care is brief treatment. The average collaborative care episode lasts about 6 to 8 months, which is actually good, considerable amount of time to really treat someone's symptoms. And given that the average number of visits in the nation for community mental health visits is something like 2, collaborative care actually has much higher engagement rates to really go through for successful treatment. Not only that, but for me, I don't even know what brief means. If you said to me, we're going to give you brief treatment, like, what does that even mean? I just want to get better, right? So we don't really use the term brief or brief treatment. Collaborative care is a lower level of care. This is actually not correct. And in a lot of cases, and particularly really good data coming out around individuals at risk for suicide, that collaborative care is actually more effective because it has more touches. I can talk to someone every day. I can teach a DBT skill and follow up. So I really think of collaborative care is one model of care. It doesn't mean that one is higher or lower. It's just one model of care. What might be higher if someone is going into an intensive day treatment program or residential, then that would be a higher level of care. But really, you want to not kind of use those terms. And collaborative care is not therapy. So one of the treatment choices in collaborative care is talk treatment or therapy. Oftentimes where people get confused is when they think therapy, they think 45-minute sessions or 60-minute sessions. The only reason we do treatment in those cadences is because that's how we get paid. There's actually no research to support that time frame. That's how we get paid. We have to use those codes to get paid that are attached to those time limits. But if we really back up and we think, what is therapy, right? Therapy is someone who's able to provide an evidence-based clinical intervention to someone with a mental health diagnosis and symptoms and be able to treat them. And that can happen at any cadence and any duration. And so really collaborative care is treatment. It doesn't happen in 45-minute sessions very often, although it could, but it is actually treatment. And one of the things we've learned, we don't treat cancer like we did 5 years ago, or diabetes like we did even 2 years ago. And so one of the things to really think about is we don't treat behavioral health conditions like we did some time ago either, or 2 years ago. We've grown and changed. And we've learned that collaborative care, or behavioral health treatment rather, is better in doses. Excuse me. Collaborative care is better in doses, so that we're giving doses like medication is often how I equate it to people. And that actually works better. And think about it in your own life. If someone's working with you on something and you're talking to them multiple times a week, that's just more effective. So if you're really interested in some of the literature that's out there, tons of randomized controlled trials and meta-analysis. And actually, there's a lot of new articles now out around adolescents, around underserved populations, geriatrics, so that you could actually look and even see some of the effectiveness in special populations. So really thinking about some of the core principles of collaborative care. Collaborative care is incredibly patient-centered. That monthly case rate is a gift because it allows us to really care for people. I don't have to follow a particular cadence. If I need to talk to Sujina every day to reinforce something or to follow up or to help problem solve, I have the ability to do that. It is evidence-based as the umbrella, but also we use all of the evidence-based practices that we know work for the diagnosis we're treating. So DBT, CBT, REBT, motivational interviewing, behavioral activation, those are things that I pull out of my tool belt all the time in collaborative care. that we're accountable. We're accountable to the population of people who have a behavioral health diagnosis. And we're really looking at the entire population. I always try to think of it like a cupcake, right? So oftentimes the frosting gets referred for counseling or behavioral health, but your whole population, the cupcake, the majority of people don't actually get anything. And one of the things around caring for the population is that, you know, not everybody needs the same treatment. It's why a lot of people often, I call it the therapy bus, right? They get on and then they don't know where it's going. They don't know why they're on it, and they jump off the first chance they get. And so collaborative care really allows you to give different interventions and touches based on what someone needs. So there's lots of different options for people. And it is very treat to target. So we're going to use those tools, we're going to get outcomes, and we're really going to continue to do something different until people get better. So this is a pretty picture of what collaborative care looks like. We're adding 2 people to that primary care team. We're adding the behavioral care manager, and I know there's some of you here with us on the call today. And that behavioral care manager works with the patient. And one of the things we know is that it's really important to work with that patient pretty frequently, particularly in the first couple of weeks, to communicate with that healthcare provider, to use a registry so that we can keep track of our patients. We don't lose anybody, like nobody falls off the radar. And then the psychiatric consultant. And that psychiatric consultant doesn't see patients and they don't prescribe meds. They meet with that behavioral health care manager once a week. And it really has to be once a week. So if you're a behavioral health care manager and your psych consultant says, I have an open door policy, that's a solid no. You really want to make sure you have that dedicated time every single week to talk about people who are not getting better, who are getting worse, who are having side effects, who might be at risk in some way. And that's happening every single week. And then they make recommendations to that primary care provider, who is the prescriber of the medications. And so the PCP still oversees all of that patient's care. They're the ones that come to at least a potential diagnosis from screening. Maybe somebody scored a 17, they put depression down in the chart. And then they say, you know, I work with Samantha. She's part of my team. She helps me care for my patients who are feeling sad. I'm going to have her give you a call later, right? So that they do that handoff. It is not necessary to have an in-person handoff. That is a big myth, not actually supported in the literature that it needs to be. Some patients need an in-person handoff, many do not. And one of the things we know is we cannot populate a collaborative care service with just provider referrals. And then, of course, the PCP collaborates with the site consultant and the care clinician. And that collaborative care clinician, that care manager, provides evidence-based treatments. They give patient education. They really follow up using their registry. They do medication support. They often have to change up treatment. They do relapse prevention and care planning. And they work closely with that psychiatric consultant who does that weekly caseload review, makes recommendations, does some consultations, and puts those recommendations in the chart for the primary care provider. So this is the most important component of collaborative care, particularly for care managers, to understand the treatment choices. And the thing about the treatment choices in collaborative care is that they can be interchangeable. So I can be in talk treatment for 1 week. I could be in all 4, and then 1, and then 3. It changes all the time, sort of based on what my needs are. And it's why the schedule in collaborative care doesn't look the same for any patient. Oftentimes people will say to me, well, I do collaborative care, and I say, show me your schedule. And I see people are scheduled every other week or twice a month. Then I know they're not doing collaborative care, because they're not flowing in and out of these treatment choices. And we don't want to tell people, here's the treatment choices, but it's really important to understand them. So we do have medication support. So if a patient is on a medication, and it's not necessary that they be on a medication to be in collaborative care, but oftentimes we're supporting them. It's really hard to take medications every day. Tell me about some times when you don't take your meds or don't take them as prescribed. Are there times when you take too much or too little of your medication on purpose? Yeah, I take more on the weekend because I want to sleep. I take less during the week because I really need to be awake at work, right? So you could work with individuals around medication support. The one of the probably ones that I use literally all the time is behavioral activation or goal setting, because this is like magic. It works literally like magic. What's something you could do today to feel less anxious? And then I work with them on a very, very small, manageable goal. Most of the goals that I see in charts that get set by primary care providers or behavioral health clinicians or care managers or are way too big. So I like to give an example because there was a guy, and I've used this example a bit because it was just a really good example. And he came home from the primary care office and he had seen a care manager and he had seen his primary care provider. And we actually gave him a call, and I was doing like a shadowing. And so we gave him a call, and they had told him that he was, needed to walk, that was his goal. He was going to walk a couple of days a week. And I said to him, how likely are you to walk? Right? Here's my motivational interviewing. How likely are you to walk? He was like, yeah, I'm not likely to walk at all. He said, because I wear house slippers all the time. Like my feet don't even really fit in shoes. I don't, I wore slippers to the doctors today. And I said, well, what's something you could do to help you feel less sad? He's like, well, I do think it would be helpful to go outside. And I always ask today or tomorrow, because then people automatically give me something small. Otherwise you get, I'm going to lose weight. I'm going to get along better with my sister, like whatever it happens to be. And so he did say, yeah, actually, I think I could sit outside, be outside. What would you need to do towards your goal of being outside, tomorrow? Well, I really would need to, I can't stand for very long. So I would have to have a chair. What would you need to do to be able to get a chair? Well, I would have to call my son and he'd have to bring a chair up from the basement because I don't have any chairs on my porch anymore. Is there a time today when you'd be able to call your son? So we actually went from walking a couple of days a week to calling his son that night after dinner at 6 o'clock to ask if he could come by and bring the chair upstairs, right? And I say, I'd love to give you a call tomorrow and see if that was able to happen. That's behavioral activation, and I use it all the time and continue to build on it. So a lot of times after I've talked to patients for a bit around meds and set a small goal, I already have time to follow up. So I don't even need to do anything else. Every once in a while, I will say to someone, it seems like you have a lot going on. Maybe we could schedule a time to talk for a little bit longer next week. And then they might be in talk treatment. I very, very seldom do that. Maybe if there's something extenuating going on or there's a particular, something, but most of the time I don't actually feel the need to do that because I have multiple times already to follow up with that person. Every once in a while, if someone says, no, you don't need to give me a call, right? Like if I'm my most engaging, endearing self and they're like, nah, not having you, right? Then I say, listen, it's really important that your provider know how well you're doing. Would I be able to call you? Is there a time that I can call you maybe twice a month to just ask you some questions and let your provider know how you're doing? That's symptom monitoring. That's I want to call the lowest level of collaborative care. And oftentimes we lose patients because they don't actually know that that's a choice for them. And am I going to chat them up when I call and talk to them? Sure. And a lot of times they wind up in behavioral activation or goal setting. But that symptom monitoring is actually a treatment choice. And so you should have at any given time about 15% of your patients in talk treatment, and the rest are usually between the other three treatment choices, with more of them being in sort of that behavioral activation and goal setting. And again, they could actually be in different ones from week to week, right? So nobody's going to look the same. No schedule should look the same. No patient schedule or follow-up should look the same. So I want to stop there for a moment and just answer any questions about the model itself or about treatment choices or anything that we've talked about sort of to the moment.
Can we speak, or do you prefer it on
Yeah.
chat?
No,
Okay.
whatever. Yeah, absolutely. Can you speak? Yes, speak, my dear, speak.
Okay. Thank you. Thank you so much. I'm wondering, how are those talk therapy, talk treatment, or behavioral activation interventions, does that get billed out as CoCM or as?
Yes. Yep, it's
Or-
part of that monthly case rate.
So it's the monthly case rate.
Yeah,
So
it's the
not billed
monthly
out
case rate.
separately.
Nope, nope.
Okay. Okay.
And that's the beauty of it, because that follow-up call, hey, did you get a chance to call your son? Yeah, I did. And he brought the chair up last night. So what might you need towards your goal of sitting outside today? Well, actually, I was planning to sit outside today. What time were you planning to sit outside? Probably around 2. I'd love to give you a call tomorrow and see how it went for you. And then I would call, and that's maybe 5 minutes, right? And then I would call the next day, calling to see, did you get a chance to sit outside? Yes, I did. Tell me, how did it feel to meet that first goal? What was it like to sit outside? What did you see? What was the weather, right? Like, I really live it up with them, right? And then I say, well, what's something else you might be able to do to feel less sad? I could plan to sit outside, again tomorrow. I could drink my coffee out here in the morning instead of in the kitchen, right? Fabulous idea. Let me give you a call and see how that went, right? And so now what happens? He goes outside, he has his coffee, he's going outside a couple times a day. He talks to the neighbor that walks by. He decides he should have another chair brought up. So he calls his son, right? Guess what his PHQ score is doing? It's going down, right? What am I doing? I'm just calling and follow up and really setting those goals. So every time I talk to him, it's not long, but it gets counted towards those collaborative care minutes. And it's like magic. It really is.
Thank you. Got it.
Any other questions about the model?
Yes. So in this situation where you're suggesting that I'm understanding clinicians call for check-ins with patients, I understood the last person to kind of be asking about how to bill that. And my concern in my particular organization is that, like, having, for example, like 11 to 12 visits a day for integrated behavioral health and developing a more collaborative model. How do we work that in so that that is something billable and it's a continual part of the process, so that you are able to not only see the patients that are scheduled, but bill for these calls, or is that something that is not what you're talking about?
So I would say yes and no. For the first part, I would answer is that this never works for the most part. 95% of the time does not work to have clinicians that are seeing patients embedded in a practice then do collaborative care. You need somebody that does collaborative care and somebody that continues to do what they're doing. You can't mix the two. It just doesn't work. People wind up with low behavioral health, like collaborative care caseloads. The scheduling doesn't work. And you're measuring, I can tell, productivity. I have to see 10 to 12 patients a day, whereas collaborative care doesn't get measured in productivity because it's monthly minutes. And so it's a very different thing, and it's just too confusing. So if you're going to do this, then you really need a dedicated person, and we can talk about sort of what that looks like and how to make it sustainable. If there are times when your clinicians are doing follow-up calls that you're currently not getting paid for, there's a code that I'm going to talk about a little bit later that I'll flag for you that you could use in that scenario.
Thank you for that. Excuse me. Thank you for that information.
Any other questions, comments?
What would be a typical monthly minute, just to have a better idea of what the behavioral health managers work, or how they, I guess, organize their work week?
Yeah, so generally it's helpful to be able to have a schedule to work from. Like, even if I'm doing that 15-minute call, I schedule it. So it is helpful to have a schedule that they can use that's in 15-minute increments. I think it really depends on your electronic health system. What we recommend is that care managers do one long running note for the month. It doesn't clutter up the chart. It helps them add up their minutes. And sometimes if you put something in a schedule, it has to be arrived. Otherwise, it goes into like EMR, whatever the version of EMR purgatory is. And so that actually is really problematic. So that might be something you have to sort of troubleshoot in terms of what kind of encounter. But generally, it's helpful to have something where they could do that scheduling.
I do have one more question, and maybe you'll get to this.
Sure.
Just thinking about some of the context of some of the other questions as well. What I have learned about collaborative care, and this might be the wrong way to think about it, is that it's, would there ever be a case, or are there programs that use like a more stepped care model where they're referring people out not out, but referring for that specialized 12-week CBT protocol? Does that occur?
No.
No. Okay.
I think if people are thinking about that's a little bit of an older way to think about collaborative care, where collaborative care now actually measuring with the PCL for trauma, patients at risk for suicide, like it really is a pretty comprehensive. So let's just say I have someone who has a diagnosis of trauma, right? They actually do really well in collaborative care. They don't often do well if you refer them to treatment. They don't stick oftentimes. And so if they go into collaborative care, they wind up doing really well. We reduce some of their daily experience. So it's not about what happened to you. It's about what are you experiencing every day and how can we change that experience? And what that does is it's incredibly empowering. I do have some control over this, right? I am able to change my experience. And then if they want to, let's just say they want to go into a course of EMDR, right? Just for fun. And so they are way more likely to go and way more likely to stay. And that has been my experience consistently. And to be quite honest, oftentimes I find that they've had several failed treatment attempts around trauma. And so I don't actually focus on what happened to you. Why give those experiences any more power? Let's talk about what your experience is now, and let's figure out ways to change it. And that actually is incredibly helpful for people. And I have found that to be very successful over the years. And then people may, even if they choose not to go, right? Then they've had a good treatment experience with a beginning, middle, and an end, and they're more likely to go in the future. So I would say absolutely very few individuals get referred out of collaborative care. It's kind of the same as if I were doing weekly therapy where I have someone that needs specialized eating disorder or substance abuse treatment. I refer those people. You wind up referring the same population of people. The only difference is if like you have somebody that has some cognitive problems or the really young kiddos sometimes, or where there's hearing problems, and because a lot of collaborative care is telephonic. So sometimes, you know, those kinds of scenarios, but no.
Thank you. That's helpful. Thank you.
So a little bit about who can be the care manager. So CMS says they don't have to be licensed. I feel pretty strongly that they need to be master's prepared just because of the tools you're using, the interventions, the patients you're seeing. It could be a student that works themselves into a job. Love that. It should be a dedicated person. They can be remote. So collaborative care is predominantly telephonic. It has been that way since day one. Before it was fashionable, before there was COVID, because it just works better. If I'm calling you to see if you called your son, you don't need to come in for that. I don't need to see you. I'm talking to you every day. I don't need to see you every day. It just works better telephonically. I also have found, and I've done this so many times, where somebody said, well, I've been thinking about raising my window blinds. Well, we've done it on the phone. Raise your window blind, right? What do you see? How does it change the look in your room? Like, we do it real time right then and there. And then we set a goal. Oh, I'm going to have coffee in front of the open window blind. I'd love to give you a call tomorrow and see how that went. Right? And so I had a woman on the phone not that long ago, and she was going to look for a particular pair of shoes in her closet. And she went into her closet, and she was so funny. I haven't seen this in years, or I was looking for this. And so I had to kind of narrow her down a little bit. And she actually moved from finding her shoes. She found something else that she used to do. It was like, I don't know what to call it, but like, it's kind of like a sewing thing with felt. I don't remember what she called it, but like that was what she was going to pull out, that bag of stuff, and just see what was in the bag. She wasn't going to make anything, do anything. She was just going to look through the bag. And so her goal changed, but we did that live on the phone. So your care manager does not need to be credentialed with any health plans, because the primary care providers are the billing providers for these codes. So the behavioral health providers couldn't bill them if we wanted to. They can only be billed by primary care providers. And so if I'm remote, I can cover multiple locations, right? I could be centralized. And so that's actually really helpful. So kind of going back to what I was talking about, all the depression diagnoses, anxiety, trauma, stress. Some organizations start with ages 12 and up because the tools like the PHQ or the GAD sort of start there. But more and more practices are starting ages 6 and up because they're folding in ADHD and using the Vanderbilt to see that treatment or that symptom reduction. And so that's an important part of this. A really big part of this also is primary care education. You're not going to be successful if the primary care providers and your medical leadership don't completely understand collaborative care, because all they've ever known is therapy. I send people to therapy or they get nothing. And I kind of like to equate it. Listen, imagine if you screened people for diabetes and you put them on metformin and then you never saw them again, right? Like, you wouldn't know whether or not that metformin is working, right? You would never do that. You measure A1Cs. And so we want to measure to make sure people are getting better, right? And also, not every diabetic needs the same thing. Some need insulin, some need a diabetes educator, some don't need anything, some need. And so now you have this care manager that can provide that array of services and touches and treatments to your depression and anxiety or behavioral health population. So I kind of equate it to the same. You don't send every diabetes patient to the diabetes educator. They don't need it. They won't go. People need different things. And so I kind of equate it, and taking away language like therapy and say treatment. so that they're not referring people for therapy or not referring people for treatment or referring people for treatment. And to give them language that literally says, I work with Clarissa. She's part of my team. She helps me care for my patients who are anxious. I'm going to have her give you a call later today. She's pretty funny. I think you're going to like her, right? And then tell them, stop talking. That's it. That's all you need to do. You don't need to, you don't need to say anything else. And really getting them to not, and to understand. And I tell patients, sometimes patients will say, well, they told me I need therapy. I say, well, you know, we've learned a lot about behavioral health treatment and that it's better, like medication, that you get it in doses. And so you're going to get a dose of me every day, right? Like, this is what we're going to do. And I don't even give that. I just turn it right around. And so having your primary care providers change that language is really helpful. So these are the codes that are used. And I'm not gonna, overwhelm you with codes. These are the 4 codes that are used. So this 99492 is the first month. Notice in the first month, outreach and engagement is included, and notice it's not included in subsequent months. And so for collaborative care, the first month is 70 minutes, an average of 70 minutes. And we're going to talk about what can be included in that 70 minutes. Follow-up months are 60 minutes. And then there's these add-on codes, and you can add 30 minutes on at a time. So you could add 2 of those 494s on. So that's 2 hours of care as an example. So this 99484 is the code that I kind of said to flag earlier, that you could use this code. It's not actually a collaborative care code. It's a behavioral health integration code. I kind of say it's the code of last resort for collaborative care, because if I don't meet the time frame for the other codes, but I get 20 minutes, at least 20 minutes, then I can use this code and I can bill for that month. It also is for people who have a behavioral health. It will cover care coordination, follow-up, those kinds of services. So you could use it in that scenario, like where I'm calling someone. You just have to make sure that that one interaction is 20 minutes or more, or that you're adding them up over the month to be 20 minutes. If I call and I do something for 10 minutes, you're poop out of luck. You're not going to be able to bill for that. And so also notice in here, and this is a very common misconception, because the term is care manager in collaborative care, sometimes people get a little confused. Notice there is no social determinants of health stuff on here. So the housing, the transportation, the food, I'm not in any way disputing that they impact people's outcomes or any of those things, but they are not included in the collaborative care codes. So you can't include in billing for some of those things. Collaborative care is the identification and treatment. And so oftentimes people get a little distracted by that title, care manager, and think that it's somebody who just does case coordination, care coordination, and some of those services. That it actually is not correct. There is another code that's 30 minutes a month. So in other words, if I only had 30 minutes and I didn't get to that 60 or 70 minutes, then I could use this code. It doesn't get used very often. And that's because there's something called the 1/2+1 rule, which applies to all CPT codes, which means that if the code is for 70 minutes, I can bill it at 36 minutes. If the code is for 60 minutes, I can bill it at 31 minutes. And so given that at 31 minutes, I could bill the 99493, I very seldom use that 30-minute code, right? And so oftentimes if it's 36 minutes and I only make 30 minutes, then I could use it. But it doesn't get used a ton. People ask about dual eligible. So people with Medicaid and Medicare, absolutely. This is a really good population to be able to do. So there are some considerations for rates. Medicare pays a little bit less for nurse practitioners. They do that for every kind of visit, not just this. Patients, unless you're in an FQHC, can be in chronic care management. I would encourage you not to exclude specialty providers, your cardiologists, your medication assisted treatment. They can actually refer patients to collaborative care. The clock does not start on the monthly minutes until the provider puts the referral in the chart. Then the clock starts. So if I engage a patient, if I meet Esperanza and her and I are talking and I engage her in collaborative care, and then she goes to see her provider and I ask the provider to put a referral in the chart, there's no collaborative care police that are going to come. Like if it's the same day, I wouldn't really sweat it too much. But if it's the next day or subsequent days, the clock really doesn't start until that provider puts that referral in the chart. So here's the things that can be included in those 60 minutes. Psychiatric consultation, so the time the care manager and the psychiatric consultant meet. So here's the important consideration. If we meet and we talk about Clarissa, right, for 10 minutes, then the 10 minutes only counts once. It doesn't count 10 minutes for me and 10 minutes for the psychiatric consultant. It's just 10 minutes, which is why the care manager usually documents it in the chart at the same time the psychiatric consultant is sending their recommendations. Discussions or reviews with the primary care provider. Time that I'm entering in my registry or updating my registry. Notice I am not saying electronic health record documentation. That doesn't count. Discussions with collaterals. Any in-person visit, phone visit, video visit, right? All of that is counted in towards the monthly minutes. We want 90% of my time to be attached to a billable episode, and we want 90% of my episodes to be billable each month, and we want an average caseload of 90 patients. Those are Verna's 390s. So if we think about what the codes are, what the reimbursement is, so you could look it up for your state or we could send it for Medicaid. You know it for Medicare online, and then you multiply it out. So if the average reimbursement is $180 a month or $200 a month, and you multiply that out by 90 patients, right? Or even if you multiply it out, generally at 62 patients, most practices are pretty much self-sustaining. So if you were conservative and you did 62 times 180, that's $11,000 a month. That generally covers your care manager, salary, fringe, and overhead, and your psychiatric consultant time. So that's often why you'll hear me say that. So anytime there, so 90 patients, you're going to have considerably higher. And that should be your average caseload, is about that 90 patients. So we know that collaborative care is going to give better care. It's going to be outcome based. It's going to be sustainable. It's really going to help you move forward. I saw some FQHCs in here. They have different codes. I'm working on this. I promise you with CMS. The G511 and the 512, they are increment of care. You can bill that 511 multiple times, and the 512, I can send separate FQHC guidance to some of you so that you'll get a chance to look for it. Couple of things to think about. Oftentimes there are limits on the 99494 codes to 2 per month. Commercial rates are really going to vary. And for your FQHCs, even some of the state Medicaid will have them use the CPT codes and not the Medicare G code. But for Medicare, you're definitely going to have to use those G codes. Yeah, I will send you Esperanza. I'll send it to Sujina to be able to send around. But it's really detailed and will be really helpful for you. You can bill some individual visits. I don't think I'm going to talk about submitting claims. I think I'd rather answer some questions on your ability to sort of get this up and running. So collaborative care does have copays, right? Not for your Medicaid, but for Medicare. So the nice thing about collaborative care, because it's that monthly case rate, if I go to see my primary care doctor and my copay is $20, I'm going to pay $20 for a month of collaborative care, which is way more affordable than having to pay a specialty copay for every therapy visit or a psychiatry visit. And so it becomes way more affordable and accessible for your Medicare and your commercial patients. For example, somebody with straight Medicare, it's going to be about $36 a month. But you are going to have copays, you are going to have deductibles for your Medicare, and you're just like you do for any other services, only it's going to be substantially less because of that monthly case rate. So there are some reasons that collaborative care implementations fail. And this is, I've been doing collaborative care implementations now for literally 20 years. And I can tell you there's really only a handful of reasons that they fail. One is that you don't get your claim forms right. The monthly case rate, the billing, we get very few denials for these codes. Oftentimes it's that the claim form is filled out wrong. The other is that there's no real organizational focus. The medical providers don't understand it, and there's no dedicated staff. There isn't a person that we say, you're going to do collaborative care. Without that, it's incredibly, I'm going to say it's almost impossible to be successful. The other is the land of perpetual launch. I have known practices that have been launching collaborative care for a decade, literally. And they get a grant and they call me up and they're like, Verna, we got a grant to do collaborative care. And I'm like, colossal waste of time. Because you really have to be dedicated to be able to do this and do this in a way that you're going to launch. I tell people 30 patients the first month. Why is this important? Your care manager starts to get a groove. Your billing people go, oh crap, there's 30 claims. I'm going to get 60 next month. I better figure this out. And your primary care providers start to get it. 60 patients the second month, boy, your care manager's really getting their groove. Your billing people are figuring it out, and their primary care providers are going, oh, this is pretty cool. I like it. I have quite a few patients that are being helped. 90 patients the third month, you're sustainable, right? In fact, you're generating revenue. The care manager has figured it out at a full caseload, or you're giving them support. You figured out ways to engage patients, not just warm handoffs, but pop health. Like if somebody calls for a refill on depression meds, they get routed instead of just getting the med refilled, right? So you've kind of figured it out. If you do that, you will be off and humming. And not that I don't love everybody that I work with, but I won't hear from you unless you have a problem. If you don't do that, I will be working with you for a long time. And so that will really help you get up and running, and you'll drop those claims right away. Also helpful to think about your depression screening initiatives, and we can certainly talk to you about some of those things. But that actually is sort of a really quick overview of collaborative care. It's a little bit different than you've been thinking about it. So there's a question in the chat about CCBHCs. I love CCBHCs. I've worked with the National Council since day one of the CCBHCs. I can tell you this, and I'll deny I said it, but it is coming, that SAMHSA actually wants CCBHCs to adopt collaborative care. And I think it works really well for CCBHCs that were community mental health centers and then became a CCBHC. If they start to do primary care or health services, it's a really hard service line to stand up. And people always underestimate how many patients are going to use it. Always. And so what you could do is you transition your patients that are med only and stable on your psychiatry caseloads. You move them to the primary care provider to continue prescribing the meds. You put a behavioral health clinician there to do collaborative care. You're billing the primary care visits, i.e. supporting your service line and improving your health measures. You're billing collaborative care. You're freeing up your psychiatric providers to take other patients, right? And so quite frankly, it works out beautifully. and you really recognize, and then it helps you meet some of your other CCBHC criteria. And then you have outcome measures. In collaborative care, we look for 50% or 10 points in 90 days on your depression or your anxiety, and then get you below 10 and below 5. So that's incredibly helpful. So CCBHCs, absolutely. This is a really good thing to do.
All right, if there are any questions, please feel free to unmute yourself. You can also type it in the chat, whichever option works best for you, but please don't hesitate to ask questions.
And I would say if you are a care manager and going to be, or hiring a care manager, let's really hop on the phone and train them. It's so important. Like, we don't do traditional intakes. Like, we don't schedule an intake. We don't do a biosite. We don't do any of that, out and Z, as my friend would say. What we really do is we kind of right in, tell me a little bit how you've been feeling. I hear you've been feeling sad. How long have you been feeling sad? When haven't you felt sad? What am I doing? I'm doing a differential diagnosis there, right? Pretty much. What's worked for you in the past? Oh, I took this blue pill, that didn't work. I talked to my religious leader, that was really helpful. I stopped drinking, that was helpful. Like, whatever it is, right? Oh, you were drinking, tell me more, right? And then just saying, well, great. Now let's start where we are. What's something you could do today or tomorrow? And I just launch right in. And one of the things we know about engagement, I don't tell anybody about collaborative care. Nobody cares. Nobody needs to know. We have this program and it's collaborative care and it's brief treatment. No. I just literally say, what could you do today or tomorrow to help you feel less sad? People just want to get better. They don't want to hear about collaborative care. And there are times when people will ask me, well, this feels a little different. And maybe I talk about it a little bit, but I certainly don't do it right away.
There's a question in the chat, Verna. Stacy asked, how does this differ from behavioral health homes?
So I think I wouldn't say differ, but what I would say is it fits nicely in because it is very patient-centered. It helps you manage certain populations of behavioral health patients with care pathways and with documented outcomes. So I would definitely say that it fits right in. Well, you guys have been pretty awesome. We are here to support you. As you go along, particularly like if you're doing collaborative care, reach out to us. Love to talk to you about how many people are you billing, what's your caseload like, how to, get more bills out the door, how to increase your caseload, what does that look like, give you some pointers, give you scripts. So please feel free to reach out to us, and we're happy to help you at any point with anything that you might need.
Yeah. If there aren't any questions, then thank you all so much for joining us today. Victoria is going to send you a follow-up email with a survey link. Please complete that for us. It really helps us to improve our training. Verna, thank you so much for your time today and for amazing presentation. Always.
So is a behavioral health clinician as a care manager so not licensed? Is that the question?
No, sorry, I mean like a behavioral health consultant, like a PCBH model.
Yeah, you could use them as long as they're going to be dedicated to collaborative care and not trying to do multiple functions. The only thing I would say, and remember I am one, okay? Psychologists, not always a great match. They don't love collaborative care always. They come at a higher salary. You're better off really to do like a licensed master's clinician, not independently licensed, somebody, an LPC. That tends to be a little bit of a better match. And then maybe have your, if you have psychologists do some other services, for people that are going to need and continue to do what they're doing. Well, thank
Thank
you,
you.
everyone. Have a wonderful day.
Thank you, everybody. Take care.